All right, hi everybody. So my talk is titled Confocal Microscopy, but there's very little confocal microscopy in my talk, so I apologize ahead of time, but hopefully you'll find what I have to say interesting anyway. So as all of you know, the human body is comprised of organs, and when you look at high resolution, you can see microscopic features of microscopic architecture, which are like glands and nerves and collagen bundles, as well as individual cells. And, you know, basically, in all areas of the body, alterations in these cells give rise to architectural changes that can result in, high diseases with high morbidity and mortality. For example, in this case, you have changes in the squamous cells being changed to columnar cells, which can undergo genetic mutations, develop dysplasia, and then ultimately invasive cancer, which can cause death to the patient. And this is a familiar paradigm in all epithelia. So my research is involved trying to see these abnormal architecture and cells and intervene at an early stage. And as all of you know, our current way of looking at architecture and cells predominantly is pathology, which is the gold standard method in medicine, where a clinician uses their eye or an endoscope to view an abnormality. Tissue's taken out of the body, it's processed, sectioned, stained, and the pathologist looks under a microscope and looks at that architecture and cellular patterns, makes a diagnosis, and then provides that feedback to the physician so that they know what to do. And this is the way that our gold standard diagnosis has been practiced for the past 100 years. But there are problems. The tissue is dead. This is a time-consuming process. It takes, many hours, if not days, to get the slides and read them out, and it's inefficient. In order to take tissue out of the body, especially inside the body, you need sedation and anesthesia. It's costly, and it's difficult and unsafe for some tissues. Like, you don't want to take tissues out of people's coronary arteries and take biopsies, or you don't want to take tissue out of the brain. Another problem is that oftentimes the disease is not readily evident, and so clinicians have to randomly biopsy the lesion to hope to get the best diagnosis for the patient. And this is common in a disease that I work in called Barrett's esophagus, where you have this reddened mucosa by endoscopy, but you don't know where the dysplasia is, so they randomly biopsy this, hoping to find the right location in the body. So all of these problems with the gold standard method have led us to ask, well, what if instead of having to do that, you could actually see at the microscopic level in living people? Well, if you could do that, you could transform pathology. So today's pathologist looks under a slide all day, looks under a microscope all day at all of these trays of slides. But tomorrow's pathologist can actually be looking at the microscopic images in real time as they're doing a procedure in the patient. And this has started a new field called interventional pathology, where the pathologist is actually an interventionalist making the diagnosis in real time. You can also transform screening and early stage diagnosis, which is really important, as I mentioned. Today, we have these really crude tools in the primary care setting where most patients present first to a physician provider. We have stethoscopes and blood pressure cuffs and things like that. But in the future, we're going to have little microscopes that you can swallow, for example, that are going to be able to screen for gastrointestinal tract diseases. And we can implement them in the primary care setting. And then, I don't know how many of you have seen the Fantastic Voyage movie or read the book, but in the future we're going to be able to have, this is going to become a reality, where you're going to have tiny little micro robots in the body that are going to have advanced microscopy on board. They're going to have artificial intelligence on board, and they're going to be able to make decisions autonomously and treat disease at very early stages before they progress to that late stage when there's really nothing you can do about it. So this is this promise has given rise to the field of in vivo microscopy. And my lab's goal is to see every cell in the human body. And this is kind of a master slide where there's this resolution size scale. There's what you can see given those size scales. And then these acronyms, OCT, OFDI, confocal, SECM, OBM, micro OCT. These are all of the different technologies that we and others have developed to look at these different size scales. So just a little primer on OCT. So OCT is an optical analog of ultrasound, and it provides cross-sectional images of tissue reflectance. And it has a low power resolution. It's about 10 to 30 micron resolution, 10 in the depth dimension and about 30 in the transverse resolution. And there's really high-speed forms of this that can image, tens of thousands of images a second, so that you can do imaging of complete organs at this very high resolution. And because of its resolution of 10 to 20 microns, it provides information on architecture. So OCT doesn't identify individual cells. And as I mentioned, we're looking at it for Barrett's esophagus. So we've developed technologies that address two problems in Barrett's. One is screening. So most people that have Barrett's don't know that they have it. About 90% of people are walking around with an undiagnosed Barrett's esophagus. So there's a big problem with screening. And then there's also a big problem if you're found to have Barrett's, is in identifying that dysplasia, so you don't have to resort to random biopsy. So if you could do microscopy to find the dysplasia and then take it out, that would be tremendously beneficial. So to address the surveillance problem, we've developed this balloon that you can put into the esophagus, and it can grab three-dimensional images of the entire esophagus. And you can see the cross-sectional images as the scanner goes back. And we can identify dysplasia and then take it out very specifically. But most of our work recently has been on this capsule OCT technology, which is designed to screen people for Barrett's esophagus in the primary care setting. And it's a capsule that's on a tether, and the tether contains the optical fiber, and it has a little beam scanning mechanism that has the beam scan around after you swallow it, and it scans as it traverses your esophagus. This is the first patient ever done. This is actually a postdoc volunteer who looks at the capsule kind of skeptically and then swallows it. But the really cool thing is that what happens is that the esophagus recognizes the capsule and compresses around it, allowing you to get full 360-degree microscopic images of the esophagus as the device goes down the organ. And this is a man who has Barrett's esophagus. And basically, it's really easy to tell the difference between squamous, which is the normal esophagus, and Barrett's esophagus, because with squamous, you have this layered appearance, all of the different architectural layers of squamous epithelium, whereas Barrett's is a change in the epithelial type to columnar epithelium that doesn't have those same layers, and you can see that very easily. You can also look at 3D. This is normal here, normal squamous, and then when you move into the Barrett's, you can see it gets really rough, and that's because the squamous epithelium is really flat, and the columnar epithelium has glandular mucosal surface, which is lumpy and bumpy. We've shown by comparing our technology to endoscopic biopsy that the accuracy of OCT for detecting Barrett's is very high, with an area under the curve of 0.94. And we've done primary care screening, and we have shown that the prevalence in the population of Barrett's is about 16 or 17%. So that's crazy in the primary care setting to have a prevalence that's actually that high. So lots of people have it, and most people who have it don't know it. So most of the time when people present with esophageal cancer, it's very advanced, and only 20% of them will survive after 5 years because of that advanced presentation of this. So it's a really big problem. The mortality rate of esophageal cancer is higher than that of many of the other cancers, even the ones that have much higher prevalence. We've also developed versions of this that add other technologies to the capsule. So this one adds white light imaging, so you can get a view that looks kind of like the endoscope, in addition to corresponding OCT images at every spot. In terms of, we've done fluorescence, so this is something you swallow. You swallow this slurry that stains Barrett's mucosa, and it doesn't stain dysplastic Barrett's mucosa. So when you swallow it and you see Barrett's by OCT and you see Barrett's with the fluorescence, if you've lost fluorescence, that's an indicator of dysplasia. So it's a way of getting more information about whether or not there's dysplasia. We've also tried to go deeper into the GI tract. So this is the stomach. This is a really pretty image, but it's actually digested food. You can see that swirly pattern is digested food. And then you can see the mucus layer and the layer of the stomach. And we tried to get the capsule down into the small intestine, but we found out that we needed to put weights in it to allow it to have gravity, move it through the pyloric sphincter from the stomach into the small intestine. And when we do that, we get these really pretty images of the duodenum, and you can see the duodenal villi. These are the absorptive architecture that exists in the small intestine. You can see it in real time and live. It's amazing to see. It looks like sea anemone or seaweed or something underwater. It's really fascinating, and we've used this to diagnose celiac disease and other malabsorptive conditions. And the neat thing is, we can let it go and we can get three-dimensional images of the whole small intestine, and we can render it in 3D, and we can see all of the anatomy, and we can also get down to the very, the architectural level with OCT. And this is a fly-through where you're in the middle of it and you're flying through, and you can see how fluffy it looks, and that's because of the duodenal villi are very sponge-like. And then this area here is bile, and when we render under that, we can see the ampulla vater, which is where the bile duct and the pancreatic duct merge and empty their contents into the second portion of the duodenum, and you can actually see bile billowing out of the ampulla. So recently we've been working with the Gates Foundation to look at using our capsule and related technologies to study a disease called environmental enteric dysfunction, which the Gates Foundation believes to be one of the major causes of poverty around the world. And this is a problem of the small intestine where, for some reason, children and adults end up with this inflammation. They have reduced absorptive capacity, meaning that if you feed them, they don't get better and they don't gain weight. And they have reduced barrier function, so the bacteria and things go from the lumen into the bloodstream easily through the gut. It turns out that this gives rise to poor neurological development, and also it causes the people to be stunted. And because of this whole entire population, millions of people are stunted and neurologically developmentally delayed, and it puts them at a competitive disadvantage with neighboring society and neighboring countries. The bad part about this is it's only reversible in infants. So you have to catch it in the first 2 years of life. So we have started by bringing our capsule to Pakistan, and as you can see on the right, a malnourished Pakistani adult has much flattened duodenal villi compared to the age-matched and sex-matched healthy US subject. These intestines are really flat, so they don't have that absorptive capacity that we have here in the United States. And then we've started developing a version of this that you can actually stick through the nose. So one of the problems is that we need to do this in infants, and infants can't swallow capsules. So we developed a version of this that goes through the nose called the transnasal imaging tube. And we're using it in pregnant women and infants in Pakistan right now. So the tube is a 2-millimeter tube. It has a balloon on it. And you can do OCT imaging to confirm where you are in the gastrointestinal tract. And once you're in the stomach, you inflate one of the balloons with a liquid metal called Galinstan, and that gives the weight that you need to allow the device to transit from the stomach into the small intestine. So it's similar to the weight we put in the capsule, but this is a liquid that we inject. And then you can do your microscopic imaging of the duodenum, as I had shown you before, and it allows you measure the heights and widths of the villi in the duodenum, and you're also able to get your three-dimensional morphology. But now that you've got minimally invasive access, you can put other tools into the device under guidance of something called M-mode OCT, which is non-scanning OCT. And you can see when it becomes in contact. And in this case, we have a cryobiopsy probe where we freeze the tip of the probe when it touches tissue. And then when we pull it off, we get a tissue sample. So we're able to minimally invasively get tissue. And the tissue is much better histology than that of a forceps biopsy, because a forceps biopsy compresses and crunches the tissue and causes compression and artifacts. We also have a brush that we bring in to grab the microbiome, and we're able to do sequencing of the microbiome, which is important in understanding and treating this disease. And we also have a new tool that we can use to measure the voltage across the epithelium, and that allows us to have a real-time measure of intestinal permeability. So there's a normal voltage of -12, and when you have a permeable intestine, it goes to 0. And we're able to also do studies in patients where we can put modulators of intestinal permeability. In this case, glucose is the modulator, and we can show that the voltage drops because there's a sodium glucose cotransporter in the epithelium of the duodenum. So this is a nice tool that we can use. It's similar to the capsule, but it's used in people who really can't readily swallow the capsule. This is just an example of a case that we did in an infant. This is a 6-month-old infant at the medical center there in Karachi in Pakistan. And we're able to insert it into the baby's nose. And then we're imaging on the OCT system, and we're able to image the baby's intestine. Let's see here, if I can move this along. Anyway, so that's our upper GI tract capsules, and recently we've developed a capsule for imaging the colon, and it's called retrograde OCT TCE or RTCE. And the idea here is to replace colonoscopy with a less invasive technology, so you don't have to be sedated. It's less expensive. It's automatic and objective, and there's fewer missed lesions, because right now about 20% of the precancerous lesions in the colon called adenomas are missed by colonoscopy, and that's because they hide behind colonic folds. And so if you could image the whole colon at microscopic level, you could potentially not have to miss those lesions. So it's the same kind of capsule, but the difference is that it has these silicone threads on the outside, and the capsule actually spins. So when you stick it into the anus, it spins and it goes all the way up into your colon. It drives itself into your colon. And then once it's there at the cecum, which is the proximal most part of your colon, you activate imaging and you can pull it back. Let's see if I can. Yeah, so, and then you can pull it back, and you grab images of the whole colon on the way back. And I see some of you in the audience making jokes. So this is a photograph of our prototype system. This is a close-up of the capsule. It's got this very soft, rubbery silicone threads. And we've done this in swine, and we've been able to image like a whole 1.5 meters of the swine colon. And the swine has a different shape of a colon. It's a spiral colon compared to an inverted U shape. And we can do our 3D fly-throughs where, you know, this is in the rectum, and then you move into the sigmoid colon and the spiral colon, and you can see all of those folds that I was talking about. We can image all of those folds. We've done this now in patients, and they're unsedated. These are enema-prepped patients when we've gone up to the splenic flexure, and we're able to get really beautiful OCT images of their whole colon. And this is just a fly-through photograph of the folds that you can see in the colon from the OCT images. What was really nice is that the patients tolerated this procedure very well. We had overall a tolerability score of 2.2, And 1 is they don't feel anything, and 10 is it's very uncomfortable, and 2.2 is a pretty low score. And nationally, the sigmoidoscopy scores are around 4 out of 10. So we're pretty happy that patients really don't feel the device at all, which is great. And then we've done a lot of work classifying adenomas with OCT, and these are Z projections. So OCT is a 3-dimensional imaging tool, so you can cut it, you can have cross-sectional images, or you can cut it in the transverse plane and get what are called Z projections. And we have classified the adenomas in a machine learning algorithm, and again have very good classification accuracy with negative predictive values of over 90%. And there's a standard in gastroenterology that says if you have a certain accuracy, then you can actually replace biopsy or excision with histology with this non-invasive or minimally invasive imaging technology, and we've met those thresholds. It's just really exciting. All right, so that's kind of a brief overview of some of the work that we're doing in OCT. And like I had mentioned, OCT is an architectural imaging modality, but sometimes you need to actually see at higher resolution and look at cellular morphology. And so we've developed this form of confocal microscopy called spectrally encoded confocal microscopy that is super high speed, and it has much higher speed than conventional reflectance confocal microscopy. And it can now go probably like 10,000 times faster than video rate. So it's super fast. And as a result, it's capable of imaging whole organs in real time. So this is an example of a reflectance confocal microscopy image of Barrett's. And you can see these little white dots here in the upper right-hand corner. Those are nuclei of individual squamous cells. And this is a high-grade dysplasia actually infiltrating into the squamous mucosa. The neat thing is you can look at low power and see the architecture, and then you can zoom in at high power and look at individual cells. And I think somebody in the audience here was part of coining this Google Earth body. So you can start at low power, and then you can zoom in down to high power. The place we've been really working on this recently is in looking at a minimally invasive way to diagnose eosinophilic esophagitis. And eosinophilic esophagitis is a food allergy that causes these inflammatory cells called eosinophils to infiltrate into your esophageal mucosa. And the reason why it needs to be treated is because that inflammation, if it's untreated, can cause stricturing and fibrosis of your esophagus, which can create a whole bunch of problems swallowing and, in the worst case, food impaction. And these patients who have it, many of them are children, and they have to have multiple endoscopies, and it's a really a big problem, clinical challenge to give, they can have up to 12 endoscopies a year, and so it's a really big problem. So what we've been trying to do is develop a less invasive way. And luckily, SCCM sees eosinophils, so those little white dots on this image are eosinophils, and that's because the eosinophil has large granules in them that reflect light very strongly. So we built these little capsules that we use in pediatric patients and adults. It's about the size of a Fred Flintstone vitamin. And we can grab these enormous confocal microscope images. So this is a 22 centimeter long full esophagus confocal microscope image of somebody who doesn't have EOE. And as you zoom down into the mucosa, you don't see any of those white dots that I showed you, which were the eosinophil cells. But in this patient who's positive, you can, as you zoom down in, you can actually start to see those white dots showing that she's actually got active inflammation in her esophagus. And again, these patients don't need to be sedated. They don't need to lose a day of school. And we can easily help ease the burden of diagnosing EOE in these patients. And we've also been now starting to go towards wireless microscopes. So our first foray into this was to develop microscopes that could be implanted into organs that before they're transplanted into patients, so that we could monitor for inflammation. And our goal was to make these microscopes really tiny so that they wouldn't cause any tissue damage. we use this technology called oblique backscattering microscopy, and it's a very simple technique that just requires 2 light sources and 1 camera. And the way it works is that if you shine light to one side of the camera, light propagates down into tissue and then comes up at an angle at the camera. And then if you shine light from the other side, it comes up to the camera at another angle. And what you end up with is 2 images that don't look like anything, but when you subtract those images, a microscopic image, sort of similar to a phase contrast microscopy image, pops out. So this is the first demonstration of a wireless implantable microscope. It's the postdoc showing that there's no wires. That metal disc in the back is a magnet that turns it on when it comes close to the device, and then it's on a phantom that has 10 micron beads, and now it's wirelessly transmitting images of the 10 micron beads up to the computer screen. And we've done this in pigs and have shown that we can get images of renal tubule cells for up to 24 hours. We've also developed a wireless thermal capsule. This is our latest wireless capsule. And what this does is it measures the temperature. It images the temperature of your GI tract as it goes down. And temperature is increased in cancers, and it's increased in certain inflammatory conditions. And so we can find hot spots and monitor them wirelessly with this device. And we're now building an OCT capsule that is completely wireless. So we're taking the enormous system and we're miniaturizing it and putting it into a tiny capsule. And we hope to be able to move these around the body. There's different control systems. There's a magnet that can control these capsules and position them all around your body. And there's also little arms and propellers that can be added to move them around. But what we're after really is to try and make an autonomous capsule that you can swallow. It will identify precancers in your body. It'll have AI on board inside the capsule that will make a decision on whether or not to treat. And then it'll use a laser therapy to treat the tissue. So you don't even have to go see your doctor. You just swallow a pill and it handles everything for you. It's kind of like a device, but it behaves like a pill. And it behaves like a pharmaceutical because you don't need physician intervention. All right, so I'm just going to finish up my lecture by talking about micro-OCT, which is our highest resolution imaging technology. And it's similar to standard OCT, but it has an order of magnitude better resolution in every dimension compared to standard OCT. And when you do that, you get much better images. So these are biopsies that are imaged by standard OCT on the right and micro-OCT on the left. And with micro-OCT, you can actually see individual nuclei. You can see individual cell membranes. And it's really quite impressive, the additional information you get. And it's close to histology. So, this is a micro-OCT image of a cervical specimen. And you look at histology, and you can kind of see the same structures in histology that you can in micro-OCT. That wasn't the case in standard OCT. And then, of course, the other advantage is this is 3-dimensional. Like, you can't get the 3-dimensional information from standard biopsies. One area that we're working in is trying to make a probe that does micro-OCT and image the inner ear to diagnose sensory neural hearing loss, which is the largest sensory deficit in the world. And it's caused by damage or some malfunction of the hair cells that exist inside the cochlea in your inner ear, and specifically in this little region within the cochlea called the organ of Corti. And the organ of Corti has those hair cells that transduce sound into electrical signals that go to your brain. And we're able to show, for example, in mice, that in normal organ of Corti mice, you can see those cells. These are the inner hair cells, the outer hair cells, these things called the supporting hair cells. But when you noise damage mice, you see that those cells go away, as in the bottom image of that says damaged. So we've been developing this tiny little probe that you can stick in through the round window of the inner ear minimally invasively. And you can put it into something called the scala of tympani, which allows you to visualize the organ of Corti. And these are nano-printed probes, so that we have a 3D printer that prints at the nanoscale. And so we can print all of these tiny little components. And they're so small that you can't make them by hand anymore. And as I said, we stick it into the round window in the scala tympani. And this is an image of the organ of Corti of a cadaver, an adult cadaver, where we can actually see those cells. We can see the hair cells, the inner hair cells, and the outer hair cells. And if you compare it to histology, like it's almost a one-to-one correlate between the histology of those hair cells. And so the reason why this is important is because there's all of these therapies that are being developed to treat hearing loss, but no one knows what any individual person's underlying deficit is. For example, there's a lot of gene therapies being developed for hearing loss, but if you don't have any cells there, then it doesn't matter if you give them gene therapy or not. There's nowhere for those genes to go, and you're not going to cure that patient. So there's a real need to be able to look and see what's going on inside the patient, figure out what is the optimal therapy to give to them, so that we're not wasting money and time trying to treat patients with therapies that cannot help them. Micro-OCT is also really good because it can see dynamic function inside the body. This is imaging of respiratory cilia. So these are like little hair-like structures on the top of your airway cells that are designed to push mucus out of your body, and they beat really fast. And you can actually see them with micro-OCT. Not only can you see them in epithelial culture and in trachea culture, but we've been doing this in the nose of people, and we can see the cilia beat in the nose, which is really important for assessing the efficacy of therapies for things like cystic fibrosis. And we've also used it to study what's going on in COVID. So when the COVID crisis was at its peak, we were imaging people inside a booth with our device to see what happened to their respiratory cells and their cilia specifically. And what we found was that unlike healthy, where you have this beautiful cilia beating all the time, in COVID, you lose all of those cilia and you end up with inflammatory cells that are sort of traversing the top of the epithelium. So that's because the COVID attacks the cells that contain the cilia. Some of you may have seen my talk this morning, but I'll just briefly go over dynamic micro-OCT. So micro-OCT is a super cool new technology that allows us to measure not only structure but metabolism in tissue. And the way it works is that you grab images from the same location over time in living tissue. And if you look really closely, you can see that inside there's like this modulating pattern of noise inside the cells. That's actually real motion of organelles inside the cells, and that's motion that is ATP dependent. So you require ATP to move organelles around inside your cell. And when you color code that, you can see all this new contrast that comes in. And that contrast is related to the metabolism of the cells. So blue is highly metabolically active, and red is sort of tissue that isn't metabolically active or dead. We've validated this. One way we validated this is by looking at spheroids. And the spheroids are untreated, are bright blue. But then when we treat them with a chemotherapeutic agent, in this case staurosporine, you can see that the spheroid goes from blue to red and green. And we have compared that to the gold standard, which is host staining and propydium iodine staining of spheroids. And it's like a one-to-one correlation between our dynamic micro-OCT and the standard live dead assay. But the advantage of dynamic micro-OCT is that the cells are still alive, whereas the live dead assay, you have to destroy the spheroids. So we have sort of a way to monitor the metabolic activity and keep the tissue alive, which is really important. This is a really nice image that shows something that's really important for pathologists, which is an understanding of the way tissue and specifically epithelium mature. So the micro-OCT image on top, you can kind of see some cells here and there. But when you do dynamic micro-OCT, the image becomes much more clear. And you can see all of the individual cell membranes. But even more importantly is that you can see that the bottom of the epithelium in dynamic micro-OCT is blue. And that's because this is squamous epithelium. The blue layer corresponds to metabolic activity, which is where the cells are all dividing. And then normally the cells mature and they divide less. They then die and slough off the top of the epithelium. And what you're looking at in this blue to green to red transition from deep to superficial, you're looking at a metabolic representation of surface maturation. And I can't tell you how important this is for the diagnosis of disease. In fact, it is probably the #1 diagnostic criteria that we use as pathologists to assess the progression from a low-grade dysplasia to high-grade dysplasia to cancer in all epithelia. And so it's amazing that we can actually see it. And even more interestingly is that as the cells mature and lose the deep blue, you can still see that there's a little bit of hazy blue in them around the nuclei, and that's because that's where the organelles are actually actively making proteins and transcribing mRNA, and they are actually causing molecular motors to cause those organelles to move around the nucleus. And we can actually see that on dynamic micro-OCTs. So that's why there's a perinuclear blue halo around all of these cells, because that's where the metabolic activity is in protein production. Dynamic micro-OCT can also visualize the same metabolic activity in all kinds of different tissue types, in Barrett's esophagus, in the liver, in the brain. It changes when you have neuronal activation, and also in the kidneys and lymph nodes. So it's really powerful because it's extensible across the body for looking at metabolic activity. It doesn't require any labels. And as you can see in this image, we can do it in vivo. So this is human skin in vivo, where you can see the same maturation pattern. You can see the basal layer is bright blue. You can see that as it goes to the top, it turns red. And we can even see increased metabolic activity in the stratum granulosum, which is where keratin is produced, which makes physiologic sense. So this is just the slide showing that we've discussed the reasons for doing in vivo microscopy. The technology OCT that allows you to see architectural morphology and all of the capsules that we've built with that. When you want to see cells, you can move to confocal microscopy and technologies like SECM and OBM, and then micro-OCT, which provides histology quality resolution without requiring any labels, and dynamic micro-OCT provides that added dimension of metabolic activity that you can't get with microstructural imaging alone. So we think that as these technologies mature, we indeed will transform pathology from today's pathologist who sits in their office looking at slides to tomorrow's pathologist who's actually looking at microscopic images in the living patient and deciding what to do in real time. To change how we do diagnosis, instead of like stethoscopes and blood pressure cuffs, we're going to be able to screen for cancer by swallowing capsules. And then ultimately, we're going to have these micro robots moving around the body, autonomously making decisions about what to do and treating the first cancer cell or the earliest stage of disease instead of waiting until it's too late and there's nothing that can be done. So with that, thank you very much for listening to my talk. This is my lab, and this is my contact information if you want to follow up on any of the things you heard today. Thanks.